dynamic hyperinflation, which is what we call auto PEEP or air trapping. So auto PEEP is also called intrinsic PEEP. So that's what we refer to as intrinsic PEEP. And this occurs when there's incomplete exhalation. So if there's incomplete exhalation, that means there's still some gas still left in the lungs at the end of exhalation. And then what's going to happen? Then the ventilator deliver another breath. And then before the patient finish exhalation, the ventilator deliver another breath. So as a result of that, the patient is going to start what? Gas trapping, right? Gas trapping. And as the gas trapping, that means the pressure at the end of exhalation. And what's that pressure called? Very good. PEEP, right? The positive end expiratory pressure. So that positive end expiratory pressure, we start to what? We start to increase. And that's what we call what? That's what we call the auto PEEP. And if that pressure at the end of expiration starts to increase, guess what's going to happen? That will start to increase the intrathoracic pressure. And if the intrathoracic pressure is increased, then that could lead to increase in right-sided afterload in the heart. And that could decrease venous return, and that could lead to hemodynamic instability. So when we look at the pathophysiology, so expiration is too short and air cannot fully leave the lungs. And this is common in patients who have obstructive lung disease. So patients who have obstructive pulmonary lung disease, whereby they're having problem with exhalation, like patients who have asthma exacerbation, COPD exacerbation, or if the respiratory rate is set too high, those patients, they're going to have very short expiration. That means they're going to do what? Gas trapping. So they're going to have incomplete exhalation. And guess what? The vents will just keep delivering more tidal volume to them, and they continue to have what? Gas trapping. So what are the physiologic consequences of this? So in terms of respiratory, this can increase the work of breathing, guys. Just imagine breathing with a full lung. The lung is still full with air, and then you breathe in on top of that, then that could increase what? Increase work of breathing. And that could make it very difficult to trigger the vent. Because in order to trigger the vent, there has to be a what? There has to be a pressure gradient, right? So if there's that pressure gradient, that could make it very difficult to be able to trigger the what? Trigger the vent. And that could also increase your plateau, and that could increase the peak airway pressure. In terms of cardiovascular, so that could increase the intrathoracic pressure, and that could lead to decrease in venous return, and that could lead to hypotension. And even patient could develop a PEARS, pulseless electrical activity arrest, especially in patients who have severe asthma. In terms of pulmonary, it could lead to barotrauma. So patient could develop pneumothorax, and they could have ventilator-induced lung injury. So how do we diagnose this? So like we mentioned earlier, so a couple of clues that you can look for is when you look at the expiratory flow, if it doesn't return to zero. So that could be one clue, because when you look at the flow, so for instance, let's say this is our baseline, right? Baseline from the previous lecture, right? So let's say this is inspiration, right? And this is going to be expiration. So ideally it's supposed to return to zero. Then the next breath will be what? Deliver, right? So that's going to be inspiration. So if you start seeing something like this, right? So you can see that one did not return back to baseline before a next breath is delivered. Then that could be suggested that this patient is having what? They might start developing auto PEEP, right? Also rising end expiratory pressure, that could also suggestive of it. Or patient having difficulty triggering what? Breath. So how do we measure this? So we have to do what they call end expiratory hold. So at the end of expiration, you're going to hold it. And then once you hold it, then that will give you your calculate, that will give you the total PEEP. So what's total PEEP? Total PEEP is the one that you set. Remember at the beginning, when we talk about ACVC, you set the PEEP. So that PEEP that you set, plus the one that the patient has generated, the intrinsic PEEP, which is also called the auto PEEP, right? So that combination of both auto PEEP plus your set PEEP, that will give you your total PEEP. So when you subtract your set PEEP from your total PEEP, then that will give you the what? That will give you the auto PEEP, right?